Comments.
I guess I better grab my iPad if there's comments to look at.
Oh, you got us up there, Jasmine.
Comments.
We're there.
I guess I better grab my iPad if there's comments to look at.
Okay. Oh, you got us up there, Jasmine.
Comments.
We're there.
I guess I
All
better
right,
grab my
great.
iPad if
Sorry
there's
for the
comments to look
sorry
at.
for the technical difficulties. All right.
Okay, so I think we're here. Put in the comments if you can hear us, please. Make sure this is working properly. It seems like we had a little technical difficulty today. And in the meantime, I will go ahead and pull up updates. Okay. Chief Burford and Chief Cepetto say they can hear us just fine. So we'll try to start sharing my screen here. And hopefully you can see it. This is Florida dashboard. So 37,439 cases in the state of Florida with 1,471 deaths. In the state of, in Pinellas County, it's 788 cases and 44 deaths. It's interesting to note that a large slice of those actually are attributable or associated with a long-term care facility. So of those 788 deaths, 224 are either residents or staff of long-term care facilities. And 28 of those deaths, 28 of the 44 deaths are patients and or staff members of long-term care facilities. So I think our current assessment that our nursing homes and ALFs and other long-term care facilities continue to be an area that we need to focus on and an area we need to continue to work to protect is correct. The other thing I will share with you is that this website that does some of the predictive modeling is certainly changing its predictions over the last few days, given the loosening of some of the restrictions. So you can see the confidence intervals on these are huge, and it's really tough to say. I mean, the confidence interval here is just where my cursor is right now is anywhere between 2 and 140 deaths. So that's a pretty darn wide confidence interval. So I think a lot remains to be seen the next couple of weeks with the way things are changing in terms of social distancing type measures, in terms of easing of some of the restrictions and close downs, puts us in a place where we really need to sort of wait and see what's going to happen here. As I mentioned last week, I still think we're sort of around the bottom of the second inning of this thing, and we've got a long way to go. And I would urge everybody to please stay vigilant with your PPE. Make sure you're protecting yourself. Make on every patient. We're going to get some more data soon about how prevalent this virus really is in our community. But until that point, and until we know that risks are down, we do want to maintain that posture where we're protecting ourselves on every single patient encounter. And please continue to do what you can in terms of social distancing and limiting the ability of the virus to spread in the community, both at work and in your personal lives. And with that, I want to go ahead and introduce Lourdes Benedict. Lourdes is the Assistant County Administrator and has been really at the point of the county's entire response to this event. And she wanted to stop by and chat with us for a little bit today.
Yeah, thank you, Dr. Jameson, actually, for inviting me to be on here today. I'm humbled, actually, to work with all of you. I think we have an amazing team. I know we've been doing this now for about 2 months. And I got to tell you, several weeks ago when I had some of those calls regarding the nursing homes, I've worked for a long time, you know. I worked for DCF for 27 years, saw a lot of stuff in my career. And I got to tell you, I was really worried. I was really worried about some of those nursing homes and what was going on. And without hesitation, you all jumped in, whether it was our EMS Sunstar folks, JP, I think I saw you on camera at a couple of those places, you know, going in there at all hours of the night, being thoughtful, being courageous, having to wear PPE, not knowing what was going to happen as you transported people. You are all just very brave in my book, and the way you handled it with such professionalism. Really, I was just in awe of that entire team. And then we pivoted and looked at our fire departments and asked for help. And without hesitation, you all jumped in. I don't know if Craig has some better data, but the last data I got was that you all reached out to 187 different locations and went in there and, helped educate, helped with infection control, making sure those people had the right amount of PPE, and really being our eyes and ears out there at the ground level. So I can't thank you enough personally from working with all of this for the last 2 months. I thank you as a person who lives in Pinellas County. I'm very proud that you all are here. I know I feel safer in this community because of the work that you all do. I know that you've dedicated your lives to doing this. You're doing an amazing job, and you should all be very, very proud of what you're doing. So I hope that when you go home, you get some rest and understand how difficult, we all understand how difficult this is for everybody right now, no matter what your job is, but you all are just amazing at what you're doing. So again, I thank you. I know Chief Jameson, I think it was on one of our executive policy group calls, I believe it was, asked, how much longer are we going to do this? We don't know, right? We don't know what's going to happen. And with what Dr. Jameson just talked about, with opening up some more, it's somewhat concerning. I know Craig has shared some of the numbers of some of the 911 calls we received last week, and some of our overdoses, have spiked, water rescues, those type of things. So I know you're going to be ramping up more, Sunstar transports, more fire departments are going to get busier. So I thank you even more for doing what you're doing right now with the nursing home. So continue to be vigilant. And again, I just can't even thank you enough for the work that you all are doing on a daily basis. I thank you from the bottom of my heart.
Thanks, Lourdes. That's very much appreciated. I can tell in the comment section that people do.
Really I can't see the comments, so okay, I hope they're okay.
A couple of thank you and you as well, ma'am, type comments. So I think that we would all echo those words. This is some incredibly amazing work that's being done under very trying circumstances. Not easy to do out there. So I know you are super, super busy.
Stay on a little bit.
Feel free to hop off.
Thanks.
Whenever you
Thank
like.
you.
Stopping by. I think next we were going to ask JP to just recap some of the work and missions that Sunstar has undertaken over this, because I think it's worth mentioning some of the extraordinary work that's been done.
Yeah, thank you, Doc. Good afternoon, everybody. And just like to also reiterate a thank you to everybody out there. The entire EMS system is doing an absolutely phenomenal job with response to this COVID-19 pandemic. I don't think we could be more proud of the work that everybody's doing right now. So kudos and thank you for everything that you all are doing. Some update on some state missions. So Sunstar has been involved with a few statewide missions. The first actually started about 4 weeks ago or so. We were part of an effort to go to over 4,000 skilled nursing facilities throughout the entire state of Florida. And we did all of Pinellas County. So Sunstar went to over 250 long-term care facilities in Pinellas, doing a survey, basically. So essentially what we did is we went into each of these facilities, we did an assessment to make sure that the facility had what they needed for PPE, making sure that they were prepared for COVID-19. And these were state-specific guidelines of questions that we utilized. There was some training each morning to each of the crews that came through webinar from the state EOC. And then each crew went out and went to each of these facilities. So over 4,000 facilities throughout the state. It's the largest mission that the Florida Ambulance Service, or Florida Ambulance Association, sorry, has put together to date. So we're pretty proud of how that went. We think that gave some very crucial and important data to the state Department of Health to be able to identify if there were any skilled nursing facilities that maybe had some deficiencies that they could help with before the problem became too significant. So thank you to all of our Sunstar crews that assisted with that mission. A second mission that we're currently and actively involved in is another statewide mission, and this has been divvied up by region. So there's a regional IMT who is coordinating the ambulances. The Florida Ambulance Association provides the units from multiple different companies through across the state, and then that regional incident commander is the one who's assigning this mission to the specific facilities and types of facilities to those units. And so in Pinellas last Wednesday, we went out and we did some actual nasal swab COVID testing at a few facilities. And then we are going out again tomorrow to do that mission. So you may be familiar with this mission if you've heard about what the National Guard had been called to do by the governor. So this is in assistance to that. So we are actually working directly with the National Guard, with the Florida Ambulance Association and those local IMTs to coordinate this mission. The goal is to do 1,000 test swabs per day per region. So for those of you who aren't familiar, there are 7 regions in the state of Florida, each region. So we're in region 4. I'm sure most of you are aware of that. So that's Pinellas, Pasco, Hernando, Hillsborough, Polk County, Hardy County, and Sumter County are all region 4. And so we're assisting with those 1,000 tests, and we're specifically assisting in Pinellas, although we will go to other areas if they need us to assist, but there's multiple agencies helping with that. In addition to that, yesterday we had a bit of a unique transfer of 3 patients out of local hospital facilities that were heading to South Florida to be placed in a specific COVID unit. So these are skilled nursing facility residents who are COVID positive, ready to be discharged out of a hospital, but still need further isolation precautions due to COVID. And so we utilized 3 hazmat firefighters to assist us with this, who rode in the back of the ambulances wearing their PAPRs, which we felt would be a much safer or more comfortable way to treat and transport these patients for 2.5 hours or so from Pinellas to Port Charlotte. That mission went off without a hitch. All 3 patients were safely transferred yesterday, and I'd like to personally thank those firefighters and the St. Petersburg Fire Department for helping coordinate and make that happen yesterday. I think that was a great mission, something that we don't really want to do. I don't like doing long distance missions like that, but in this case, it was something that we felt was important for those patients to be able to get where they needed to continue to get the care that they need to get on the mend and recover from COVID. So thank you to all the crews involved, the Sunstar crews, the fire crews, everybody who assisted with that yesterday. Outstanding work. Couldn't have gone any better. So with that, I think that's really the gist of the missions that are going on. The COVID testing mission with the nasal swabs is ongoing every day. It's a different region. So we'll be Wednesday and Saturday this week in Region 4. So you may see Sunstar units at skilled nursing facilities assisting with doing that COVID testing. That mission is going to continue as long as the governor wants it done. So we'll continue to assist that as needed. Thank you, Dr. Jameson, for the opportunity to speak to the group today.
Awesome. Thank you very much for the update on that. And I just want to echo that transport that went yesterday was just such a great demonstration of teamwork and what we're capable when we come together with the various disciplines and the various expertise to take really excellent care of 3 people who were in a situation where not too many people wanted to take care of them. And we came through and did the right thing. And it was just fantastic. So thank you again for that.
Absolutely.
Chief Tedesco, did you want to, or would you walk us through a little bit of what the fire departments have been up to on the second round of facility visits, trying to do more verification and training and getting through all that kind of stuff?
Yeah, so to my best knowledge, most of the fire departments have gone around to and called and followed up with a lot of the long-term care facilities. We're finding many different things out at each of these facilities. I will tell you overall, the facilities were very, very appreciative that we were reaching out to them. Very pleased that we actually cared enough to do that, which is really good to hear. I received a lot of positive feedback from the inspectors from our department, and actually going out myself personally, receiving that feedback too. So we are trying to do the best we can with getting a better handle on what the long-term care facilities are doing, in combination with the information that Department of Health is sending out to us on a seeming daily basis as far as COVID counts and things along those lines. So certainly very, very much appreciated.
Yeah, and I want to thank you. I know you personally went out and did some of this work, and you identified a couple of situations that we were able to relay to the Department of Health and make an intervention, hopefully before anybody got sick or ill. So to you and your teams, thank you. I really do appreciate it. Craig, do you want to just take us through how broad a mission that's been? I mean, it's been just incredible work.
Sure. Yeah, good afternoon, everybody. Just really an incredible mission. They're putting together a dashboard. I'll share it. I don't know quite how to use it, but I'll just kind of show you that we have a total of 424 survey responses that have been done. And so we're capturing a conditions, action, and needs report, either on an on-site contact, 72 site visits, or a telephone contact. And by and large, you can see, some really, really great results here where I'll just go to, I'll just pick one where we have 0, COVID positive patients, 0 PUI residents, 0 employees with COVID. And there you show, not 43 residents and 88 employees. So just something like that, getting a good sense of what's going on out in the community. Most were considered to be low risk level. And then the high risk, we're making sure that we're connecting back with Department of Health for their follow-up and things that we're seeing. Here's another good example, Westminster Shores, 293 residents with only 1 PUI that's being evaluated. So a lot of really great work that's being done here, across the board, which kind of ties to my overall comments is, I just had an opportunity to send out a bunch of emails to show our EMS and Fire 911 appreciation video. And it gave me just a chance to kind of, kudos kind of around the board. And we have seen just incredible support, top down, county administrator, assistant county administrator, Department of Health, emergency management. Everybody's really gone just above and beyond. So the flow of patients to hospitals are April, 99.8% of patients were placed with hospital staff within 15 minutes. Our EMS calls are still flat, but there is an uptick in trauma and overdoses. So typically I'm calling this spring fever. People are finally getting back out to go to the beach or out on a boat. We've had a number of multi-patient incidents over this last week. A total of 35 trauma alerts, overdoses at 118. Normally that's around 100, so that's a pretty significant increase. We've had a number of vehicle crashes, a couple with fatalities, or 5, 4, 3 patient incidents that I'm looking at here. And so that's something that's important is, Dr. Jameson was talking about New York City that, you had a COVID patient and it was a shooting, or it was the vehicle crash and it was also a COVID patient. So being careful while you're out there. I think we all, are excited to run just a plain regular call and not a pandemic call, that you are going to see, potential for COVID on your vehicle, crash with extrication or your air transport upgrade. So that's something really, to keep in mind. We are doing another ALF nursing homes support call tomorrow morning at 9, and that'll be all hands, fire and EMS, as well as the ALFs and nursing homes, and just to reconnect and continue to connect the joint processes of PPE testing. We're mostly doing train the trainer and support, ensuring that they've got PPE and a good linkage with emergency management, and then just good situational awareness of each facility. So that's just critical. Something that's been very important to us, especially from the field side, is if you see something, say something. We've had a number of these cases where we've made really good interventions. Chief Tedesco had one this morning in which they went out there and it just didn't seem quite right. And so we passed it along to Department of Health, and that on to ACA, the regulators for Agency for Healthcare Administration. And we're seeing them really being proactive with when we're sending them something. So really keep that coming. That's critical to everything that we're doing. And we're trying to hit these hotspots very quick, so there's a small number of patients, not letting them grow and fester until there's dozens and dozens of patients. And that really equates to, literally lives saved and fewer people, really, dramatically impacted. We have approval for the PS Tracks project, so we're excited about that. Seminole, Pinellas Park, Lellman, and TI have already been using it. So we'll be rolling out vehicle checks and medical bag checks, narcotic control tracking. Chief Tedesco led that group, so we'll be finalizing all of the narcotic and controlled substance tracking protocols, and then there'll be a light amount of training. It's web-based, so it's pretty easy to use. And then that'll be followed by asset tracking. So a lot of good things going on there. That'll be coming up over the next couple of months. We'll have a project timeline here pretty quickly. We do have a change in the way that helicopters are being operated. So Bayflight is back at the medical center on the roof, and MedTrans is now the helicopter provider for the Bayflight team. And then separately, Air Methods has stayed in the region and is now branded as Air Life. And so our primary first out will still be Bayflight 3, and then Air Life 3 will probably be our backup because they'll be based at Tampa International. Still following all the same protocols for the field of dispatch will give you the full ETA with lift time and flight time, and then your air-ground decision goes back to our regular trauma transport protocols. I think that's it for me, unless there's any questions.
I just had one other system update on this. Palms of Pasadena PCI.
Oh, yeah, good point. So we're going to show that on hospital status for the next month or so. Because of the decrease in volume of patients, they have shut down the cath lab at Palms. And if that becomes a permanent situation, we'll update the hospital resources. But for now, so that there's a good reminder, it'll show in hospital status for probably the next 6 to 8 weeks, Doc, is that?
Yeah, we were told initially 45 days and then they would reassess.
Okay, very good.
All right. So there was one or two questions during that from Chief Tokars. Craig, Chief Tokars was asking if that dashboard link is viewable by the FDs.
We are working on it, not quite yet. It's on the internal county system. And so I'm working with our folks to get a link and a login for each of the FDs.
Cool. And then Chief Tokars also asked if the DOH is still making tracking efforts with COVID positive patients. So yes, the DOH is still doing those types of contact tracing and is actually planning on ramping that up as we progress. I know that Dr. Cho told me that he's expanding his group of folks who can do that type of work, recruiting people from other divisions of DOH to augment that. I think even recruiting like masters in public health students to come augment that. And so he is working on that. And actually I did ask him, and I'm hoping he will join us on this YouTube live next Tuesday to try and answer some of any other questions that folks have for DOH. So I think that would be great.
Hey, that's very cool. I know that you've always wanted to be a DJ, got the whole setup and everything. So now you've got a call-in show. So I'm pretty excited for
Oh boy, here we go.
you.
So another question from Chris Main is any update on COVID testing for system clinicians? So there's been a lot of discussion and a lot of movement on testing recently. And the big one you've heard about is that there are now, I guess, walk-in, for lack of a better word, without an appointment testing sites. Lourdes, you'll have to tell me if I'm saying this right, but I believe there's 3 additional sites that are either opening or just opened around the county. And I don't know, you probably have those right in front of you, but basically the idea is you don't have to necessarily make an appointment. You can just roll up and get tested. Is that right?
Yeah, basically, we're partnering with the community health centers. So there's one in St. Pete, Pinellas Park, Clearwater, and they're going to open one at the Lealman Exchange on Monday. And they're Monday through Friday from about 10 to 2. It's free. If you do have insurance, they are going to charge your insurance, but you don't pay anything. They prefer that you call the community health centers, and all that information is on the Pinellas County website if you need that, and make an appointment. But like Dr. Jameson said, you could either walk up or drive up without an appointment.
Yep. And so Peggy, in response to your comment, we just ordered 2,000 tests, hopefully for us. The initial order that we had placed, as I mentioned previously, the FDA changed the rules midstream on us. So the initial tests that we ordered, we decided we didn't want to use those anymore given the new FDA regulations. And so we've ordered new tests that are made in New York and have FDA approval for point of care, finger stick, IgG, and IgM testing. And what we've managed to do is form a partnership with the lab at TGH. And so if everything comes together on this, I hope that we will have that within just a couple of weeks here. There's obviously lots of moving parts when you're talking about high complexity labs. So not only are we going to shift to the ones that are FDA approved under emergency use authorization, but we are also going to do our own internal validity study on those before we push them out broadly and test a large group of people. So you will probably hear a call for volunteers to be among that first validation sample here over the next few weeks. Additionally, we had news from the state today that the state of Florida has managed to get their hands on 200,000 of the antibody tests. This is the other point of care test that was approved by the FDA, and it's called Celex is the brand. The difference is that one is only approved for a blood draw, not a finger stick at this point. And so they are starting that testing actually tomorrow down in South Florida and some of the areas with heavier impacting. And we may see some of those tests come here as well, but we're not sure yet. And as I said, right now, they're only a blood draw. They're not a finger stick. So we're trying to see if we can get a test that we can do here as just a quick finger stick and get you the answer on IgG and IgM there. But we want to make sure we do that in a responsible way that complies with the FDA regulations and that we're all confident in the test is telling us what we think it's telling us. Yes, ma'am.
So I also failed to mention that Advent Health, starting on this Monday, May 11th, is also going to have a site. They're able to do about 500 tests a day. They're going to do that for about 30 days, and it'll start on Monday. And again, free of cost. So look for more information on that.
Thank you. Yeah, and I also want to reiterate the fact that DOH has really come through for us, and we at EMS have a supply of swabs, and if somebody needs to be tested, we can test them. We can get them tested and get an answer through the DOH lab. We still have that capability. So if somebody needs to be tested, just say so, and we can get somebody tested. You have to obviously go through your chain of command. And then we will arrange for a test to be collected and sent to the state DOH lab. We've been doing the collections right at Sunstar headquarters. So I believe we're pretty good on where we need to be in terms of being able to test a symptomatic person that we're trying to evaluate for whether or not they have COVID. And I think we will get to a good spot in terms of doing serologic or IgG, IgM testing understand better how the virus is moving through our community. So I think there's a possibility that, you know, the fourth mission that we're all assigned will be to help test a large slice of the community using these point of care tests. I don't know that for sure yet, but I think that's a possibility down the road. And, you know, just as being asked to help in any kind of future vaccination campaign might be something that we would certainly be called upon to potentially help with. So, you know, stay tuned for these further missions, but it is important that we know that the tests are accurate, that they're FDA approved, and that we have confidence in that they're telling us what we think. Particularly, Chief Magnus, the implications of a positive IgG versus a positive IgM are a little bit unclear right now and a little bit complicated. So theoretically, IgM is the one that is the antibody that you develop while you're acutely ill and fighting the disease or fighting the virus, and then IgG is the memory one that you develop later on. So the way I remember that in med school is IgM for immediate and IgG for guarding you later. And so the IgG takes a couple weeks to show up, and that is the one that would theoretically confer some immunity. Again, we don't know that for sure. There was some initial reports out of South Korea and some other places that people who had already had IgG testing positive, then later on tested positive for COVID again. There was a recent post in one of the infectious disease listservs that information is now being disputed. So it remains to be shown for sure whether IgG gives you long-term or lasting immunity, but that is certainly the hope that it would, and that would be helpful in controlling the spread of the virus. So we are going to start, if everything comes together, we're going to start by actually using these fingerstick tests on a group of us, and then using them also on a group of hospitalized known COVID patients, and make sure that they're performing the way we hope they would perform. And then we would roll them out in a broader fashion. So that's the plan at this point. Hopefully by next week, I'll be able to tell you that all the pieces are coming together, and it will be here shortly. But there's obviously a lot of moving parts, and even literally last night, the FDA released updated guidance on this. So we're trying to stay as compliant as we can. Chris is asking, he says at one point, the state fire marshal states that he thought firefighters would be used to help the National Guard meeting their testing objectives. I haven't heard any discussion about that, Chris, and I think what you heard from JP earlier is that through the Florida Ambulance Association, there's been ambulance strike teams or ambulance folks tasked with supporting the National Guard on those tests already. That's ongoing and continues, and even tomorrow, Sunstar folks will be assisting the Guard in doing that. So I haven't heard any discussion of the fire side of the house being asked to do that, but that is a mission that we as the entire system are supporting right now. So I don't see any other questions quite yet. So Chief Tedesco, by way of introduction, we resumed our monthly quality meetings this afternoon, and we had a lot of things on the agenda. But one of the themes that emerged from all the folks on the call was that we believe we are starting to see a little bit of a struggle with providing full care and meeting our usual standard of care and implementing all of our usual treatment bundles when also faced with having to use PPE, having to work under the assumption that somebody might be contagious or infectious with COVID. And so that's not an easy thing to do that kind of high quality clinical care in those difficult circumstances. And as part of that discussion, Chief Tedesco wanted to bring up a particular clinical issue that might be useful for us to talk through a little bit. So, Chief.
Yeah, one of the things we were talking about is, at least I feel, and I'm trying to communicate that to all of our folks, is that a lot of people have not called 911. As everybody knows, our call volume has gone down, and there's a lot of different reasons why that could be. But one of the main reasons is people don't want to go to the emergency room, and what that causes is when they do go into dire straits, when they have a really bad problem, that's when they typically will call, or we may find them and they're already deceased. So one of the things we need to make sure that we do is have a higher index of suspicion for the folks that we're running on, and maybe be aware of that nonchalantness if that happens to creep in. And like Dr. Jameson said, we have a lot of things going on. We've been hit with a lot of different pieces of information in a short period of time, where now we were dressed differently. There's a psychological aspect to that. People are in full face masks and things along those lines. That can lend itself to maybe lessening some of our assessment skills. Now, to that end, there's something that I want to bring to everyone's attention, and that is the possibility of stroke. I have a friend of mine who unfortunately very abruptly lost her son on April 25th. It was very sudden and very abrupt. He was in his late 30s, and he simply had arm pain. And I know that may sound very weird, but he had excruciating pain in his arm. That actually drove him to the emergency room. In a very short period of time, he actually succumbed to a PE because that DVT traveled to his lungs. And by that time, there wasn't anything that the hospital could do. He ended up being COVID positive. Now, in the research that I've done since then, recognizing that there is a age group between 30 and 50, whereby we need to be careful if they are complaining about any kind of numbness or any headache or something along those lines, that they could actually be COVID, and they have a high propensity for having a stroke because COVID-19, and Dr. Jameson can speak to this a little more. They're finding out that the actual COVID virus is having a major effect on our coagulability, and it's a blood issue. So I want to make sure that our folks have a good index of suspicion, that there is a high propensity of folks that are stroking out and subsequently dying, secondary to things such as CVA and heart attack and things along those lines. I want to make sure that we have a really good index of suspicion, that we don't allow the PPE or any other preconceived notions about COVID to dissuade us from making a really good assessment for the most part. So Dr. Jameson, you can chime in, I'm sure.
Yeah, thanks. So there has been a growing discussion about the hypercoagulable state associated with COVID infection. And I think we even had some questions on this on the last YouTube. And so there's a couple of studies now that are coming out that are basically saying that we're seeing markedly elevated D-dimers and markedly elevated fibrinogen levels in these patients. So it's a severe hypercoagulable state. It is not a consumptive coagulopathy, quite like DIC or disseminated intravascular coagulation. But what we're seeing is really significant hypercoagulable states where people are having strokes, people are having MIs, people are having DVTs and PEs, and all sorts of other thromboembolic type complications. And this is something that is gaining a significant amount of attention. There's also some thought that this may be related to a vasculitis type picture. So if you remember way back somewhere, you probably heard of something called Kawasaki's disease, which affects kids. So for the parents, this is why your doctor ever said, if the fever lasts more than 5 days, you have to come see me. Because if you have symptoms of certain things after a fever of 5 days, that's a clinical definition of Kawasaki's disease, which can be devastating to a child's arteries, particularly the coronary arteries, and can cause all sorts of problems. So Kawasaki in med school, the mnemonic was Kawasaki, or not mnemonic, but the memory aid was Kawasaki kills kids' coronaries. And that's a vasculitis that can be very difficult. And there's now multiple case series being published about kids presenting to the hospital with Kawasaki-like vasculitis and all sorts of complications from that. Even if they don't have the classic form of Kawasaki's, that actually may be the way that COVID manifests severe disease in pediatric patients. So it's a little bit interesting to see that this darn virus keeps us on our toes and keeps showing us new ways that it has to wreak havoc in people. Whether it was initially the cytokine storm and hyperreactivity of the immune system, whether it was the fact that now one case series was like up to 40% of people were presenting with GI complaints as their initial complaint. Now we've got kids with a vasculitis. We've got people with strokes and PEs and heart attacks. This sucker just keeps evolving and changing how we see it manifest in disease. So Chief Tedesco's point about maintaining a high index of suspicion and really being thorough in your assessments is incredibly important. Again, this virus continues to sort of amaze us in terms of how it has spread, how it manifests itself, and how difficult it is to control. There was also a discussion earlier today about the fact that there was a patient in December in Paris who they now think had COVID, like long before anybody thought this thing was in Europe. And they now, in retrospect, are pretty convinced that that person has COVID. And so really what we know about this thing is changing a lot. And we're also going to find out more with this testing, and we're also going to find out more with the fact that our hospitals are getting their testing. So for example, TGH, where I work, testing every single patient at the time of admission. And that will tell us a lot about how many previously not known cases are out there in the community. I'm just going to stop a second because Jasmine, the YouTube looks like it's acting funny. Did we lose our?
You are cutting in and out a little bit on the Zoom.
I think it's my internet connection might be having a little moment. So if you lose me,
Join back in. Yeah, your bars are red.
okay. I think I might be back now, but I'm not sure. I think I just had a momentary interruption. Can you hear me?
Yep, I can hear you.
Okay, great. So what I was saying is that we really need to be on our toes in terms of our assessment, because there's so many different ways that this virus can present itself, and that we're going to continue to learn a lot about this thing over the next months, which I think is probably a good segue into the fact that we need to think a little bit as a group about how we make this what really amounts to a new normal sustainable. I mean, it's going to be a long time before we take off our masks. It really is. It might be the end of the year and we're still running calls in respiratory PPE. So I think we need to start thinking about how we're going to remain effective, remain operationally effective as it gets hotter and we're wearing PPE, and remain clinically effective when our senses are blunted by wearing the PPE and we're distracted by fear of contagion or other issues going on. I mean, these are things that will really mess with your assessment of a patient and your thought process and your analysis of what's going on with that patient. So we as a group need to think a little bit about how we best navigate that going forward. And so I would ask that everybody start thinking about, and maybe even start sharing in the comments, what have you learned about caring for patients in PPE and how you have to alter the way that you approach a patient or the way that you assess a certain thing on your patient. So here's an example I'll just give to start out the discussion is that in the hospital where we're all wearing masks, the patients never see our face really. So it's hard or harder to establish that doctor-patient relationship if the patient has no idea what you look like. You know, all they see are your eyes because everything else is covered by a mask. And you know, the same thing applies if you're wearing an SCBA mask or a P100 or an N95. And so we came up with these little like handouts that they were putting together for us. It was like a little introduction sheet that said, "Hi, my name's Dr. Jameson," and had a picture of me without a mask on. That "I'll be your doctor today. This is what I look like. You know, sorry for all the PPE, but we really are here to care for you." And that was an idea that one of the docs came up with there in terms of overcoming a barrier that the PPE presents. And so I guess I'd like to hear from the other folks who are watching along with us, or Chief Tedesco or Jasmine, what they've felt in terms of difficulties while wearing PPE and ideas for overcoming that. So while I wait for people to put those comments in, looks like Sean, are you still allowed to be on this YouTube after you left? I don't know. I guess so. All right, fine. So Sean says, more people at home with sedentary lifestyles having DVTs just because they're sitting on the couch. That reminds me of that old commercial about saving the world in 1945 was like the dudes heading off to World War II, and then saving the world in 2020 is like sitting on your couch in your pajamas, staying home. Yeah, so interesting.
All those Netflix related DVTs. I think my teenager's at risk for that.
All right, so we've got some comments. So how far into the incubation period of the virus are you starting to see the hypercoagulation? I don't think we know that yet, Danielle. I think what I'm hearing it mostly from is the in-hospital treatment, which would argue for it's further along, but we don't know whether that's just because we don't know about it or can't see it sooner. So I don't think we know the answer to that yet, Danielle. Peggy says, you told us to wrap them up and transport and only minimize treatment other than nasal cannula or non-rebreather. So yeah, we did. And that's a good point, Peggy. But that doesn't change the fact that we need to now learn how to do this better and more sustainably going forward. So I think in the beginning, we were all kind of in a mode of we need to protect ourselves. We don't know what's coming. Is this going to turn into what we saw in New York, where their cardiac arrest volume tripled? Or is this going to be a slow burn, or what's this going to look like? And so I think at this point, and you guys know this just as well as I do, it's sort of a steady, slow burn, and we have to figure out how to live with this thing, which means we have to figure out how to do as best care as we can while we're still staying safe. So let's see, pre-assigned roles during codes is really important because you may not know who you're talking to. Yeah, I think half the time we don't know who we're talking to on a regular call, I think, but hopefully we do. Yeah, so Chris, are you suggesting that we pit crew out or pre-plan out more types of calls? Is that, am I reading you correctly, or is that not the suggestion you're making? And then while I'm waiting for you to answer that, Peggy says having to scream and ask assessment questions is exhausting when you can't breathe well. Writing down the questions helps. Okay. So I know we were using dry erase markers on like the walls of the ambulance and stuff. Jasmine, do you know if that was being done on top of Visqueen or right on the wall of the ambulance?
I'm not sure, but it should wipe off either way.
Then we have anything that we are using to be able to write back and forth to the patient? Peggy, do you need some kind of equipment for that, or what would make that easier? John Michael says right on the wall. Chris says, yes, we should be pit crewing more or pre-planning more. So Chris, can you give like a specific call type that you think we should pre-plan? Ooh, back of the 1, 2, 3, 4 laminated card. Interesting. That's a good idea. So we could even put some more laminated, just blank pieces of paper in there to use to communicate with some dry erases. Okay, that's a great idea.
Yeah, Peg said they've been using the laminated card, so I think that's a good one. We should add some of that.
Put in a blank white one that they could use to write back and forth with. Voice amps for the SCBA. Yep, that was certainly something that some agencies were able to deploy, which was very helpful, I think. Chief Tedesco, I think you were able to get those going, right?
That is correct, yes.
Those were helping a lot?
Yes, big time. We're trying to get better with that, and we're trying to find the HEPA material for the new filters that we created. Trying to get that HEPA material is gosh awful difficult. We thought we had a line on the HEPA material, but then we lost it. So now we're back trying to find the HEPA filter. Once we have that HEPA filter medium, like I said, we'll have the newer cases, the newest cases that we 3D printed for everybody. So that'll be helpful. But I think one of the things that we're doing right now is talking about it and making it aware and acknowledging that, you know, being in this PPE, being in these full face masks is really challenging. And like I said, there's a psychological thought process that comes with this. And we need to sort of do the best we can to work through that to provide even better patient care than what we're giving. And, you know, while doing the long-term care facility assessments, for lack of a better term, something I learned that I didn't really think about. A lot of the owners of the facilities or the caregivers of the facilities, they were bringing one very common point, and that was they were having a difficult time with the residents during dinner or during lunch, because the residents during dinner or lunch, they wanted to sit with each other. A lot of these residents places, or excuse me, a lot of these facilities, they don't have the ability to put them in a fairly close to each other, is what I'm trying to say. And they all want to sit next to each other just because they want someone to speak to at dinner. And it's a huge psychological problem for them. I think bringing points up like this brings a human element to all of this. By us having all this PPE on and we're all we're talking is viral this, viral that, we lose that sensitivity for the human element. And by what we're talking about right now brings that humanness, that human essence to it, that who we're treating, they possibly were quarantined by themselves, or they're stuck in a room by themselves for a long period, or a simple act that they can't sit next to someone that they sat next to for the last 4, 5, 6+ months, and they have no one to speak to during dinner. These are all really important things to start to stop and just think about. We've got to bring the humanness back into our medicine outside of this PPE, this robotic sort of look that we now have that's very foreign to not only us, but our patients. Just thoughts and that's really all. Thoughts.
What a great point, Chief. In addition to the technical stuff of how to get past the PPE to make your assessment, how to make that connection with your patient and be that comforting person for them and have that human connection is really difficult, but so important. So I guess this is our call to the system to think through any ideas, solutions, tips, requests for different or other equipment or whatever else it is you all think that you can come up with in terms of ideas to overcome those two hurdles and figure out how to best care for these folks, please go ahead and send those on up, and we'll look at them and try and figure out if we can do it. Chief Barr says pinning a picture of yourself on the PPE gown lets the patient focus on you as a person, not a faceless clinician. As long as we're not putting a hole in the gown. Yeah. So I've never even seen a clear N95, Peggy. Do they even exist? Obviously there's hurdles here with the PPE, but let's keep working together to figure out what's the best way to overcome those. Peggy, send it if you have a website or a picture, email it to me. Let's keep working to figure out how we keep the humanity in this and keep the technical excellence in this as we go forward in this new normal. Because
with regard to treating, I think Lieutenant Johnson has a real good point, and that is pre-planning some of the calls that we would typically go on. If you're going on a chest pain, if you're going on a stroke or something along those lines, maybe pre-planning that in a matter of who's doing what, kind of a pit crew model. You've got this, you've got that. It may make it easier and get you back into that concept that we've got to do 12 leads. We've got to treat, with nitro or whatever it is we're doing, if that makes any sense. I think that might be something to help. We're already used to doing that. Maybe we start doing that in some of our other type calls as well.
I see what you're saying. So kind of assigning roles and responsibilities before you have to don your PPE. Is that the idea?
Yes. And if you're working with someone for the day, or you're working with someone consistently, it may be a decent way, or maybe a real good way to sort of, in the beginning of your shift, or even as you're going to the call, who's going to do what. It takes a lot of the memory work out of it, and again, it takes a model that we're already used to and assigns it to these other calls, something that we're used to doing.
Yeah, and I heard another point that somebody brought up. I don't know if it was in the comments or somebody said it, but doing the IMAC can be very, very difficult when you have these communication barriers. So how to get past that? How to make sure that we're still being diligent about error prevention and stuff. Pinellas Medic says seat assignments both on the fire ground and on an EMS call. Exactly. I think it's still this way. It's been a long time since I rode in the back of a fire engine, but I think it's still this way that, one person's got the irons and one person's got the water can and one person's got the other stuff, right? So pre-planning that kind of role while you're still en route sounds like a great idea. Okay, what else? What other ideas do you guys have from the field? And I think we have, while we're waiting for that, I just want to say thank you to our Assistant County Administrator, Lourdes, for taking the time to join us today. I think you guys probably don't know this, but Lourdes, I don't think has been home in 2 months. I think she's been working straight. It's been really
Thank
amazing.
you.
So thanks for taking the time to join us. Really appreciate it.
Keep up the great job, Dr. Jameson.
Take care. Chief Bar's the fire lingo. It's been a long time, Chief, since I went to basic firefighter school. Long time. And we called it different stuff up in New York. It was the can man and the irons, and the other person had like the trash line. So, all right. So what else do you guys have in terms of ideas for how to overcome both the connecting with your patient and getting the full and detailed assessment done while still staying safe? I'm really interested to hear what you guys have come up with, because I know you've been doing this for weeks and weeks and weeks now, and figuring out what works and what doesn't work. I'm going to start playing music again if they don't comment. I'm going to do it. Pre-made script cards. Tell me about that, Chris. What do you mean? Peggy.
I don't think we need to make it complicated. I just think we need to start thinking about it the way we're thinking about it now. I think pre-assigned uh, assignments and things along those lines are good. I think we just hit everybody with a real good dose of, hey, let's slow down a little bit. You know what I mean? And I think as we move forward, we'll start to get better ideas as to how best to bring that human essence into things.
Okay, I see where you guys are going with this idea, and I think it's fantastic. This would be really easy to do. One side of the laminated card could be blank, and the other side of the laminated card could have big print that said, "Do you have any allergies to medicines? Do you have any past medical history problems?" That kind of stuff, and you could like point to it, right? And then that kind of thing. Does that sounds like what you guys are saying? What? Are you muted, Chief?
Yeah, not point. We want to bring humanness into this. You want to communicate or whatever, or at least something to drive the conversation. The point is to actually have a conversation, not the point. It's not the happy face thing. How do you feel today? And one of those things.
But when they can't hear you, and they're hard of hearing at baseline, and they can't see your lips to read your lips, you're going to keep screaming to the blow in the face. So, okay, this idea is evolving. So each medic has a laminated card, and in one corner of the card is a picture of them without their PPE on, and say, "Hi, this is me. My name is so-and-so." And then could have some pre-canned questions on it, like, do you have allergies? Have you ever had surgery? That kind of stuff. And then the other side is blank for writing back and forth with the patient. And Peggy, I'm gonna put the music on if you keep it up. So I think this is a really cool idea. It seems like Chris Main is volunteering to take a stab at one. What do you think?
I think he just signed himself up.
And then maybe he could. He said sure already. Perfect. This is great. What a fantastic idea. So a quick picture of you saying, "Hi, my name is so-and-so. I will be your paramedic today." And then a couple of canned little things you can use to ease some of the initial communication about some of the technical pieces like history. And then the ability to write back and forth on the other side. And then it comes with disposable dry erase or deconnable dry erase marker. Then you can just wipe everything down at the end. Sweet. Okay, that's one. Who else has got a good idea? Chris. And Peggy, please join us on the next YouTube and show us the interpretive dance. How about that?
Yes, and Chris will be making a training video about this card next.
Yes.
I can't wait.
All right. Any other ideas? Again, this is how good ideas start. So this is really amazing to see you guys thinking about how to do this the best way for your patients. Laminating paper patient care reports. I don't know. It feels like
and then have them fill them in themselves. No, I mean, the thing that we're going to come up against, I think, is different levels of, people aren't going to be able to see it if it's small print. There's multiple languages. There's different levels of education. So some people aren't going to be able to read it, but it will be a tool that you can use for some patients. So I think it's a good idea. But
yeah. Somebody made the point that even after COVID, you could use that for any patient you have that's hard of hearing. At baseline, any day, that could be a useful tool to you.
Yeah.
And somebody said you could just at least have a demographic section on there that you could help get information from them if you're struggling for basic demos, like date of birth kind of stuff, right? That would help. Somebody else said flashcards. I guess that would be an alternate way of doing it, Marshall, if you want to take a stab at, a small number of flashcards that you could put on like a little metal ring that are laminated and you can decon. That could be another way you could do the same thing. So I think we're open to all ideas, and these are all really good ideas I'm seeing come up here. So I'm going to keep asking this question. So keep thinking about these ideas, and please email me or Jasmine or whoever, and keep these ideas coming, because I really do believe that this is going to turn into our new normal for quite a while. And we are going to have to get better at doing this, and we are going to have to get more comfortable at doing this, and learn from each other as we go through this. So, okay, yeah, perfect. There are the emails. You can shoot them in. I will also ask in some other forums and methods. So with that, I think we've been at it for over an hour, and I have another call in 10 minutes about nursing homes, of course. So let's give everybody a final opportunity. So throw in a couple of last questions if you have, and we'll do our best to get through them. And then I do think that we probably want to, oh yeah, good point, Chief. Even if you have an issue, but you don't have a definite solution, email the issue as well, okay? I think if everybody's in agreement that we should probably start doing these once a week on Tuesdays. Is everybody in agreement with that instead of twice a week at this point as we learn to live with COVID? Okay, here's a couple of questions that we missed, but I've heard some New York EMS agencies have added pink eye as one of the screening questions. I have not heard that, Dan, but I will ask. Was that New York City or upstate New York? So I know who the right person to ask is. About Ken says about 20 years ago, Sunstar had the basic questions in a booklet in multiple languages. That's an idea for something to go back to. And Chief Magnus says, tracking ICU beds current at 24% available, lowest since this started. Do we know related to COVID or just increase in other cases? I didn't see that low availability on my numbers this morning, but it may be. The number of COVID patients in the ICU remains fairly low. So I do see a breakdown on the data dashboard that I get of how many of them are COVID. It's still a pretty low number. I think this morning, as from memory, I don't have it in front of me, but I think from this morning, there were only 9 people on vents in Pinellas and something like 30 total in the ICU. That were directly COVID patients. I do expect, though, that our hospital capacity will begin to be taken up as elective cases start up again, and as people sort of stop hiding out in their homes as much, just as our call volume will continue to go up. So we will be watching the hospital status very, very closely between turning back on elective cases, increase in people out and about with trauma and stuff like that, and a potential for a second wave of COVID here now that the restrictions are loosening. We have to keep a very close eye on that. All right, so it sounds like the consensus is once a week at this point, and then if we were to ever go to condition red, then we would consider going back to 2 a week. And so that means that our next one will be next Tuesday at 3 p.m., right, Jasmine?
Yes, we will. And I think this was pretty good. If you guys have any speakers that you want to see, shoot us an email or throw them in the comments, and we'll see you next Tuesday.
Yeah, I am. I'll just plug it right now. I am trying to get Dr. Joe from the health department to join me next week, and I can try and find another speaker as well. If folks have somebody in particular they want to hear for, just email me.
Dr. Osterholm.
He was supposed to be on the Eagles today, but he got called away, so I can ask him.
I know. That'd be awesome.
That website, by the way, just to make sure everybody knows what it is, it's the, what the heck is it called, Tony? The Center for Infectious Disease Policy, CIDRAP.
Yeah, CIDRAP. It's awesome.
CRAP. Just Google CIDRAP. All right. I don't see any other new comments. So I think, Jasmine, if you're good, and Chief, if you're good, I think we'll call it a day.
All right. Stay safe out there, everybody. We'll see you next week.
Take care, everybody.
Thanks, everybody. Have a good night. Be safe.